Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, SIRFLOX, randomized phase 3 trial comparing first-line modified FOLFOX6 with or without bevacizumab versus modified FOLFOX6 with or without bevacizumab plus selective internal radiation therapy in patients with metastatic colorectal cancer by Van Hazel et al. My name is Andrew Koh, and I'm a professor of medicine at the University of California, San Francisco, in San Francisco, California, United States of America. My oncologic specialty is gastrointestinal medical oncology. Selective internal radiation therapy, better known to many as radioembolization, represents a technology in which an yttrium-90 radioactive payload carried by microspheres measuring between 20 to 60 microns in diameter is delivered directly and selectively to areas of the liver via the hepatic artery. This approach leverages the unique dual blood supply to the liver, whereby liver tumors receive their main blood supply from the hepatic artery, while normal hepatic parenchyma is fed primarily by the portal vein. The conceptual appeal of this strategy, along with a greater understanding of radiation dosimetry to the liver that allows for its safe application, and the frequency with which malignancies develop within or metastasize to the liver, makes selective internal radiation therapy, which I will refer to as SIRT from here on in, an increasingly utilized treatment modality for both primary and secondary cancers involving the liver. While the greatest experience to date with SIRT has been for hepatocellular carcinoma and metastatic colorectal cancer, various institutions, including my own, have also been evaluating the efficacy of SIRT for a whole host of other disease indications as well. However, it would benefit us to take pause at this point and ask ourselves, for which of these various clinical indications do we have irrefutable level 1 evidence that this technology confers a demonstrable benefit, especially in patient longevity? It is quite instructive to glimpse into the annals of JCO to gain a better understanding of the chronology of clinical trials evaluating the application of SIRT to metastatic colorectal cancer. Back in 2007, Sharma and his colleagues from the University of Oxford published their results from a phase 1 trial of radioembolization plus modified FOLFOX4 systemic chemotherapy in metastatic colorectal cancer, with 18 of 20 patients, or 90%, demonstrating a partial response and a median time to progression in the liver of greater than 12 months. A subsequent study published in JCO 2 years later by Van Hazel and colleagues showed somewhat more modest results when SIRT was combined with single-agent irinotecan. Following these single-arm studies, one of the few randomized phase 3 trials to compare systemic therapy alone versus systemic therapy combined with radioembolization was reported in JCO in 2010 by Hendlitz and colleagues, in which the focus was exclusively on patients with liver-limited metastatic colorectal cancer refractory to standard chemotherapy. These investigators found that the addition of SIRT to protracted infusion of 5-FU resulted in statistically significant improvements in both time to disease progression in the liver and time to progression anywhere, with hazard ratios of 0.38 and 0.51 respectively. However, one needs to point out both the small sample size of this trial with an N of 46 and the absence of survival benefit with SIRT, although it should also be noted that almost half the patients on the chemotherapy alone arm did subsequently undergo radioembolization at the time of their disease progression, which may have obscured any survival differences. Regardless, this trial, in addition to a number of other single-arm studies, many of them retrospective in nature and reflecting single-institution experiences, have been the primary bases for informing the extensive use of SIRT for metastatic colorectal cancer at many centers. All of this to say, in the contemporary era of more effective systemic therapies for metastatic colorectal cancer, we have lacked robust prospective randomized trial data regarding the benefits of adding SIRT to liver-exclusive or liver-dominant disease. Essentially, it is fair to conclude that this represents a technology whose uptake in real-world practice has outpaced the evidence base we typically require for therapeutic oncologic interventions. This provides the framework for and highlights the importance of the current SIRFLOX trial. In the article that accompanies this podcast, this phase 3 study, which enrolled an impressive 530 patients internationally, randomized chemotherapy-naive patients to receive either standard of care chemotherapy alone or chemotherapy with the incorporation of SIRT during cycle 1 or 2 of treatment. Of course, eligibility criteria plays an essential role in assessing which patients are appropriate candidates for and may most likely benefit from radioembolization. In the study, patients with ascites and main portal vein involvement were excluded, and quite appropriately, very specific limits for extrahepatic disease in lymph nodes and lung were delineated. However, there were no other defined rules regarding the extent, number, or location of hepatic metastases for which a patient may qualify. This certainly represents a key question for the provider who is trying to decide whether to refer his or her patient for liver-directed therapies such as this. At the very least, it is important to point out that the majority of patients, approximately 3/4, had less than 25% liver involvement. The trial results themselves are not necessarily that surprising. When added to standard chemotherapy, SIRT, as one might expect, improves progression-free survival in the liver with an 8-month improvement in median liver-specific PFS, and also increases the overall response rate in the liver. However, when considering any or all sites, there was no difference in either PFS or overall response rate, and furthermore, the addition of SIRT did not increase rates of metastastectomy. Additionally, a higher incidence of serious adverse events were observed on the radioembolization-containing arm, including a numerically higher number of grade 5 adverse events, namely toxicities leading to death. So how do we interpret these results? To be clear, the primary study objective, demonstration of an improvement in progression-free survival at any site, was not met. The authors note that a relatively high proportion of patients, 45%, had their primary tumors in place and suggest that this may have impacted the PFS endpoint to an unknown degree. Additionally, we do not know whether better control of liver metastases may potentially translate into an improved quality of life, a lesser likelihood of developing hepatic failure down the road, or most importantly, overall survival. The current study does not report overall survival results, although this will ultimately be evaluated as a pre-planned combined analysis with data from 2 other frontline studies that are also looking at SIRT. In the end, should results of the SIRFLOX study dampen our enthusiasm for recommending radioembolization to patients with colorectal cancer who have liver-dominant metastases? While this trial by no means closes the book on this technology for this particular clinical indication, for now I would suggest being much more circumspect in its use. This certainly applies not only to metastatic colorectal cancer, but perhaps even more so to all other types of solid tumors that metastasize to the liver in whom we may be tempted to think about radioembolization without a wealth of supporting prospective data. When counseling patients regarding what we realistically hope to accomplish with such procedures, we should be very clear in acknowledging what the available data tell us, or don't tell us, so as both to temper expectations and to allow the most well-informed decision to be made. Once we have mature survival data, as well as a readout from other studies addressing the same topic, we should hopefully have a clearer picture as to what kind of future SIRT has in metastatic colorectal cancer, and in what specific circumstances it may be most useful. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.